Hello, everyone, and welcome to today's virtual MBC Impact Series event. It is January 2025 somehow. Thank you for joining us today. I'm still going to say Happy New Year as it is our first event of the year. So welcome. Thank you for giving us your time. My name is Casey Volpe, and I'm manager of MBC initiatives here at Komen. So today we have a really exciting presentation focused on new treatments and approaches to ER-positive metastatic breast cancer. And our featured speaker is Dr. Sara Tolaney, and we have a lovely moderator, Carly Dixon. She's currently living with metastatic breast cancer and is a wonderful advocate. If you've never attended a series event before, the programming is envisioned as a year-long conversation. So every month is a different topic, so you can pick and choose what is most valuable or helpful or relevant to your journey, and catch recordings after the fact as well. Before we begin, I just want to take a moment and thank our 2024 series sponsors. So thank you to our premier sponsors, AstraZeneca, Gilead, and Merck, and thank you to our signature sponsors, Daiichi Sankyo. One housekeeping note. While our speakers are talking, we want you to get your questions in through the Q&A feature at Zoom. It's a little button down at the bottom of your screen. We'll get to as many as we can. Now, we have a pretty good size group today, so we'll go through and try to get through as many as efficiently as we can. If you pull up the Q&A and you see other questions that have already been asked that are similar and or the same as yours, I'm going to ask that you not ask your question twice, and so that we can hopefully get through more. But like I said, we'll work as fast as we can to get all of your wonderful questions in front of Dr. Tolaney today. But please remember that our speakers cannot provide individual medical advice, and so they're only speaking to their experiences, and try to keep your questions general, okay? Towards the end of the programming, I'm going to drop a survey link in the chat. This is really important feedback for me as the person who manages the program to make sure I'm providing really good content, topics, and speakers to you guys. So don't be shy. Let me know how today went. Let me know what else you'd like to learn about or who you'd like to hear from. That really is helpful to me planning. Now, I get to introduce you to a wonderful volunteer I have the privilege of working with on a regular basis. So her name is Carly Dixon. She's a Texas native. She's a mother to an amazing 22-year-old. I guess he's older than that now, Carly, though.
Almost 24, yeah.
Oh my gosh, 24. And two great rescue dogs, one of whom was serenading us earlier. Carly grew up in a Texas cattle ranching family and went to Texas Tech University, where she earned her Bachelor's of Arts degree in journalism. And she now lives in DFW. Carly received a de novo stage 4 diagnosis in January 2021. Since being diagnosed, she's elected to retire early from her very long technology sales career in order to slow life down and to focus on family, friends, and thriving. Carly's surprise diagnosis inspired her to learn as much as possible about breast cancer and takes every opportunity to educate friends and acquaintances about breast cancer prevention, encouraging monthly self-exams, and to be a great example of a stage 4 thriver. And then she also happens to enjoy traveling, golfing, taking long walks with her dogs, gardening, volunteering in her community, and spending time with her family and friends. Carly, my dear, the floor is yours.
Well, thank you so much, Casey. And thank you to all of you ladies and caretakers and gentlemen who have joined us today. As Casey mentioned, I have been living with metastatic breast cancer for just a few weeks longer than 4 years. I was diagnosed de novo, meaning I'd never had an early breast cancer diagnosis. I'd had a lot of aches and pains, and a sneeze resulted in a compression fracture in my back, which let me know that I, was one of those that was chosen to fight and thrive with this disease. So I know those of you who are living with the disease or you're caretaking for someone with the disease, research is really our hope. Our hope is that not just a cure is found, but that more and more treatments and ways to treat metastatic breast cancer are in the lab, are in trials, and are coming to market so that we can enjoy longer lives, feeling better, and really keeping this disease at bay as long as we can. So for all of you out there in the same shoes of me, I stand with you. It is not an easy journey, but I think information is power, and that is exactly why we're so lucky to have Dr. Sara Tolaney with us today. Dr. Tolaney comes to us. She is the chief of the Division of Oncology at breast oncology at Dana-Farber. She is an associate professor of medicine at Harvard Medical School, and she's a senior physician at Dana-Farber. So really, you guys know that Dana-Farber really leads a lot of the research and treatment of metastatic breast cancer. So please join me in welcoming Dr. Tolaney. And Dr. Tolaney, the floor is yours. Oh, you're on mute, Dr. Tolaney.
Oh, thank you. Thanks so much for having me, and thank you for the very kind introduction. So today we're going to talk about metastatic hormone receptor positive breast cancer. And so I will say many of you may have seen there's been actually a lot in the press that has come out over the last week in hormone receptor positive disease. So I think a lot of very exciting news in this space, and we'll try to touch on a little bit of it today. So I think, as this group very well knows, breast cancer is certainly not one disease. We've grouped breast cancer into 3 general subtypes, but it actually is probably far more complex than this. But at a general level, we know that there are 3 basic receptors on breast cancer cells: estrogen, progesterone, and HER2. And if a cancer has either estrogen or progesterone, we would call it a hormone receptor positive breast cancer, meaning that that cancer is dependent on the presence of estrogen for its growth and survival. There are also cancers that can have lots of copies of the HER2 receptor. And so if they have so many copies of the HER2 receptor, they can be what we call HER2 positive cancers. And that's probably only about 15 to 20% of breast cancers. And if they don't have any of those 3 receptors, we consider it triple negative breast cancer. So that's a cancer that doesn't have estrogen, progesterone, or HER2 on the cancer surface. One thing that we've really done is we've tried to develop therapies that are really based on the individual patient subtype of breast cancer. So today we're going to be focusing on treatments that were really studied in patients that have hormone receptor positive disease, but some of these information will also pertain to patients with other subtypes, because some of the drugs that we use can be used across the different subtypes, just in different scenarios. But I think what you're going to see as we talk is that we really need a lot more information than just knowing if someone has estrogen and progesterone and HER2 on the cancer cell surface to be able to make a treatment decision, because we've really gotten to a point where we are really trying to personalize treatment decisions to the individual patient. And so in order to do that, we need to know if someone may have a germline mutation that has predisposed them to develop breast cancer. So for example, does a patient have a BRCA mutation, a mutation that is something that we can take advantage of if present, because there are drugs that tend to work well in patients who have particular germline mutations. And so getting genetic testing is actually really important to help us guide treatment options. The other thing nowadays that has become very important is to understand what mutations exist within the tumor itself. And so this can be done either by sequencing the tumor tissue. So a biopsy, for example, that has been done can be sent to get sequenced and understand what mutations may be altered in the tumor to tell us how that cancer may be growing, so that maybe we can turn off the growth by knowing what's driving its growth. We can also now do blood draws where we can get DNA being spit out from the tumor into the bloodstream and then test it to see what mutations may be present in the tumor. And that's obviously a little easier than doing a biopsy because it's just a blood draw. There are pros and cons of doing different types of testing, but it's really nice to have that available now. So we do also need to know what mutations are present in the tumor. And now we also don't just look to see if someone has a hormone receptor positive or HER2 positive or triple negative cancer, but we also need to understand sometimes how much HER2 is on the cell surface. So even if someone has a HER2 negative breast cancer, it is important to understand if there's a little bit of HER2 protein on the cell surface, because there are drugs that work in that setting. And we'll talk about why that is important. But as you can see, we actually need to gather a lot of information to be able to help figure out the best treatment options. And so what I thought would be good today to talk about is what are some of the newer treatments that are available? How do we utilize these for patients who have hormone receptor positive breast cancer? And what also may be up and coming that's also really exciting. So I think the big news in my mind is that the pace of drug development has dramatically changed over the last, 5 to 10 years. So if you look at the number of drugs that were approved by the FDA between 1995 and 2015, you can see them listed here. However, if you look from 2015 to 2025, you can see an explosion has occurred. And literally, I feel like it's almost every week we're hearing something new in the news that's either getting approved or coming with new data. So I think, to me, that's what's really exciting, is that there are more and more effective therapies that just keep emerging, which is obviously very important, because I think it is really changing the trajectory of how cancers are responding to treatment. And so one of the big things that came out about 10-ish years ago, almost 15 years ago now, when they were first developed, were CDK4/6 inhibitors. And so, again, this group is, I know, really on top of things and probably knows all about this, but these are drugs that really are trying to stop the cancer cell from growing and dividing. And so you can imagine hormone receptor positive breast cancer cells are not just dependent on the getting fed by estrogen, but they're also dependent on being able to replicate and make more copies of themselves. And so in order to do that, a cancer cell needs to go through the cell cycle. But these cancer cells are tricky, and they've really revved up the cell cycle. And so they try to make lots and lots of copies of themselves, but using these drugs, these pills, the CDK4/6 inhibitors, that stops that replication process. So in essence, that cell can't replicate anymore. And so it kind of just falls asleep because it can't be active. And so a cell that's asleep for a really long time eventually will die. And so it's pretty clever to be able to shut down the estrogen and not let estrogen feed the cancer cell and also stop it from replicating. So what we do is we give a hormone therapy that gets rid of the estrogen, and we give a CDK4/6 inhibitor to stop it from replicating. And we have found that this has dramatically changed outcomes. In fact, before these drugs existed, we would give the hormone pill by itself. And now when you add the CDK4/6 inhibitor to it, it in essence doubles the duration of time that cancer can be controlled. And so it's really a dramatic change. And so there are 3 different CDK4/6 inhibitors that are available and are FDA approved, and many of you have heard of these drugs: palbociclib, also known as Ibrance, abemaciclib, also known as Verzenio, and ribociclib, also known as Kisqali. So all of these are very effective CDK4/6 inhibitors. But one of the challenges are there obviously can be some side effects of these pills. Sometimes it can lower blood counts, for example. Sometimes it can cause a little bit of diarrhea. So there can be side effects. And so we've always wanted to, always trying to look to do things better. So there are a new group of drugs that are being studied called selective CDK4 inhibitors. So they're getting rid of hitting CDK6. They're just targeting one part, CDK4, which is the critical part that's needed for the cell cycle. And by sparing the CDK6 inhibition, they've made a drug that seems to have a lot less in the way of side effects. So people's blood counts, for example, aren't falling like they were before with these newer drugs. And it seems to be a very effective way to shut down the cell cycle. So there are a few companies now that have started making these drugs. I'm showing a picture here, which is the Pfizer agent known as atirmociclib, currently still in clinical trial testing. This is just a picture, which is showing how much the tumor shrunk in response to getting atirmociclib. The bars, when they go down below the line, are showing shrinkage. And so you can see that people's cancer is really shrinking. There are very few patients to the left of the curve where the tumor grew. Most everyone has had significant shrinkage from using these drugs. And these drug was initially studied in patients who had already seen the standard CDK4/6 inhibitors, meaning the cancer had progressed on either palbociclib, abemaciclib, or ribociclib, and then they got this drug, atirmociclib, and had this level of shrinkage. So to me, that's really exciting because it suggests there's another way to hit CDK4 that may work even when you've had another one of these drugs. So again, this drug is in testing now in clinical trials, and there are a few other companies that are also making CDK4 selective inhibitors. So I think this is really nice to see that there's going to be even potentially more potent ways to inhibit CDK4 that are up and coming. So what does all this mean? I think for right now, traditionally when someone is diagnosed with metastatic hormone receptor positive breast cancer that is not HER2 amplified, so something that's not HER2 positive, generally speaking, and again, there are some caveats to all this, most of the time we're giving a hormone medicine and a CDK4/6 inhibitor. That's a pretty typical first treatment that patients are getting. Again, there are some nuances to this. Every once in a while, someone may get chemotherapy instead of doing this approach, and we'll talk about a few other nuances, but this would be a pretty typical thing that many patients are getting when they're diagnosed. But there are trials now that are studying twists on this, maybe swapping out the endocrine pill to maybe something that could be better, swapping out the CDK4/6 inhibitor, maybe for a CDK4 selective inhibitor, adding on a third drug to make this work even better. So there are lots of trials, again, taking this backbone and kind of using permutations on it. So while we talked about CDK4 and 6 inhibitors that are trying to not let the cell replicate, the other approach is to say, well, why don't we make better drugs to shut off the estrogen signaling? Because these cancers are so dependent on estrogen to grow. Why don't you just develop medicines that really do a better job at shutting down that signal? And so here's just a little picture showing how estrogen is needed to bind to the estrogen receptor. And once it does, it sets off a whole bunch of activation of various genes to cause that cell to grow and divide. So you could imagine if you just get rid of this estrogen here, then it can't tell the cell to grow and divide. So that's one trick. You guys are probably familiar with pills called aromatase inhibitors, things like letrozole, anastrozole, exemestane. Those are pills that get rid of the estrogen. So in essence, there's no food to feed the cancer cell, telling it to grow and divide. So that's one really, good trick. But I think the other strategy is to say, well, if the aromatase inhibitors are getting rid of the food, another way would be not mess with the estrogen level, just don't let it bind well to the receptor so it can't stimulate it to be able to tell the cell to grow. So that's another way, is inhibit the binding. And another way would be to just chew up the whole estrogen receptor so it can't signal at all. And that's what we call selective estrogen receptor degraders, or SERDs. They're just chewing up the whole thing. And so I think a lot of new drugs are these oral SERDs. It used to be that we just had the shots, fulvestrant, which I'm sure those of you who've had this don't particularly like getting the shots because they're shots in the buttocks. And the problem was that fulvestrant is like a thick, viscous solution that's kind of slow to be given as an injection. And so it'd be much nicer to have a pill version of that. And so there actually now is an oral pill called elacestrant, which is also chewing up the estrogen receptor. And when this pill, elacestrant, was compared head to head against other forms of hormonal therapy, so it could be that someone got fulvestrant or they could have gotten an aromatase inhibitor. They just randomized patients to either get elacestrant or a different hormone pill. Elacestrant was better than these other choices if the patient's tumor had what we call an estrogen receptor mutation, so an ESR1 mutation. And you can imagine here that if you go back to this picture, if there is a mutation in the receptor, then it's going to make the cancer not care if the estrogen's around. It's just going to be able to signal on its own and tell the cancer cell to grow and divide. So that means even if you give it a pill which gets rid of estrogen, the cancer cell doesn't care because it's developed a mutation in the receptor. So it's just telling the cancer cell to grow and divide even if there's no estrogen around. And so the way around that is just to chew up the whole receptor so that it can't signal. And that's what these pills do. And they seem to be particularly effective when there is a mutation in the receptor that's telling that cell to grow and divide. And so that's what this trial showed, is that this pill, elacestrant, worked really well if the tumor had developed that mutation within the receptor. And so one could ask, well, how do you know if your cancer has that mutation to know if this pill would be a good thing to get? And so that's where it becomes important to be able to know what mutations are present in your cancer. And one thing that we often do is we draw blood. And so, as I was alluding to before, if we draw blood and that blood has some of the DNA that's being spit out from the cancer cells, then we can sequence that DNA and understand if the cancer cell has that ESR1 mutation. And it turns out that about 30 to 40% of hormone receptor positive breast cancers will acquire that mutation after they've seen an aromatase inhibitor. So if you've had a pill like letrozole, anastrozole, exemestane, those are pills that get rid of estrogen. And so in response to that, the cancer is saying, well, how can I figure out a way to grow even if there's no estrogen around? And so it says, let me develop a mutation in my receptor. Let me make an ESR1 mutation. So about 30 to 40% of cancer cells, after they've seen that kind of a pill, will have this mutation. And so when someone's cancer has grown after they've been on an aromatase inhibitor pill, it's really important to draw blood to know if they've acquired an ESR1 mutation within their tumor, to know if this kind of a pill would make sense. And so now we are standardly checking periodically to see what mutations are in the cancer, because it does change over time. And so while we have one pill, elacestrant, that is approved to chew up that estrogen receptor, so an oral SERD, we're obviously trying to figure out ways to make these treatments work even better. And so one thought would be, why don't you combine these oral SERDs with another targeted drug? Just like we talked about at the beginning, we often will give either an aromatase inhibitor or fulvestrant with the CDK4/6 inhibitor. Well, why don't we do that with the oral SERDs? Why don't we combine them with CDK4/6 inhibitors or PI3 kinase inhibitors or other targeted drugs? And so there are a ton of clinical trials right now ongoing where this is exactly what's being done, is they're using different combination therapies. So trying to match a really good medicine that's chewing up that estrogen receptor, but also matching it with another medicine that's going to also prevent that cancer cell from growing and dividing. So another targeted drug that has been proven to be very effective is a pill called capivasertib. This is a medicine that turns off what we call the AKT or PI3 kinase pathway. And so one could ask, well, what the heck is that? What are you talking about? And so if you could imagine the estrogen receptor, when it's telling the cancer cell to grow and divide, it does so by activating a bunch of pathways within the cancer cell, and one of those can be the PI3 kinase pathway. And so if that pathway has a mutation in it, it's just going to start signaling the cancer cell to grow and divide. And about 40% of hormone receptor positive breast cancers will have a mutation in the PI3K pathway, whether that's within the PI3 kinase portion or even below it in the pathway. So you can see the PI3 kinase pathway also turns on the AKT pathway, can be inhibited by the PTEN pathway. So if you have a mutation in any pieces of this pathway, PI3 kinase, PTEN, or AKT, it is signaling the cancer cell to grow and divide. And so it would make sense to just shut this whole thing down. And so there are lots of ways to do that. There was a pill that has been approved called alpelisib. That is a medicine that is a PI3 kinase inhibitor that will shut this part of the pathway down, the PI3 kinase pathway. And now there is this pill, capivasertib, that is shutting down the AKT pathway. And so when they had patients who had already had a hormone medicine and their cancer had grown on that medicine, they then randomized patients to get fulvestrant, so the SERD, that's that injection medicine that's chewing up the estrogen receptor, and they gave that with or without capivasertib. And it turns out that if the cancer had a mutation in either PI3 kinase, AKT, or PTEN, then the combination of fulvestrant and capivasertib did much better than just giving fulvestrant by itself. Meaning if you shut down that PI3 kinase AKT pathway and give a hormone therapy when there's a mutation in the pathway, it works really well. So we need to know if the cancer has a PI3 kinase AKT or PTEN alteration to know if a drug like capivasertib would make sense for that particular cancer. So it is now standard to check to see if people have that mutation. But just to remind you, this was done when someone had already had their cancer grow on another hormone pill. There is, however, now an approval for a different drug that turns off the PI3 kinase pathway called inavolisib. This medicine was just approved a few months ago, back in October, and it was approved as the very first treatment that patients got once their cancer had come back. And so let's say someone had a breast cancer, they had been on, had it treated with surgery, radiation, and had been on a hormone pill, but their cancer came back either while they were on that hormone pill or just shortly after stopping it. In this trial, those patients whose cancer had come back after having seen a hormone medicine already, if that cancer had a PI3 kinase mutation, then getting 3 drugs, so getting fulvestrant, the hormone medicine, with palbociclib, that CDK4/6 inhibitor, with inavolisib, the PI3 kinase inhibitor, was better than just getting fulvestrant and palbociclib. And it was dramatically better. So it doubled the duration of time that cancer was controlled if you added on the inavolisib to the endocrine treatment and CDK4/6 inhibitor drug. And in fact, just a couple days ago, we saw a press release that suggested that not only did it double the duration of time that the cancer was controlled, but it allowed women to live significantly longer by getting inavolisib. And so I think it makes it really critical now that when someone is newly diagnosed with metastatic breast cancer, if that cancer had come back shortly after seeing a hormone medicine, then you really need to know if that cancer has a PI3 kinase mutation to know if giving all 3 drugs here makes sense. So giving fulvestrant, palbociclib, and inavolisib. It used to not matter if someone had a PI3 kinase mutation when they were first diagnosed, because everyone was just getting a hormone pill and a CDK4/6 inhibitor. But now seeing these data, it's telling us we really do need to know if there's that mutation. So we are now testing patients up front. I am sending a blood draw in addition to sequencing patients' tissue to know if this mutation is present, because the blood draw is a little faster. I can get the blood draw results usually within 2 weeks to know if the mutation is present, whereas it usually takes us a little bit longer to get the tissue results back, sometimes up to a month. And I really want to know this quickly so I can figure out the appropriate treatment regimen. And so while we have these drugs, inavolisib, capivasertib, alpelisib, all these pills that shut off the PI3 kinase pathway, the problem is that they do cause side effects that sometimes can be challenging, one of which can be really high blood sugars, which can be a pain to deal with. The other thing is they can sometimes cause rash, which can also be quite frustrating to deal with. And so we really do need to do better with developing drugs that really don't have quite as much in the way of side effects. And so there are a new category of drugs that are being developed that are still in clinical trial testing, which are what we call mutant selective PI3 kinase inhibitors. So they're really just trying to hit the mutation and not hit what we call wild type PI3 kinase. So they're just trying to hit where it's really driving the cancer to grow so that it's not causing quite as much in the way of side effects. And so there's this pill, Relay 2608. This is by the Relay Therapeutics company in clinical trial testing, which already has data showing that this agent is very active and has robust efficacy. And then there's this agent by Scorpion, STX478, also mutant selective PI3 kinase inhibitor, where their initial data also looks very robust with great activity. And both of these agents seem to have a lot less in the way of side effects than we've seen with other PI3 kinase inhibitors. We're not seeing as much in the way of high blood sugars, not as much in the way of rash. So they do seem to be better tolerated. So I think, again, nice to see these drugs in development, and there are lots of trials ongoing with these agents at this time, either with a hormone pill or even in what we call a triplet combination, so giving a hormone pill with a CDK4 or CDK4/6 inhibitor and giving the PI3 kinase inhibitor. And so lots of opportunities to think about getting these kinds of agents if there is a PI3 kinase mutation that's present in the tumor. And then there's been an explosion of what we call antibody-drug conjugates. So I'm guessing you all are familiar with this idea, which is, I think of it as a way to get targeted delivery of chemotherapy into the cancer cell. So one problem with chemotherapy is that, we give drugs that really are killing any rapidly dividing cell in your body. It's not just killing the cancer cells. And so you can get a lot of side effects, and that can limit the amount of chemo that we can give. And so a better way maybe to give chemotherapy is to try to target the delivery of the chemo into the cancer cell. That way you can give a lot more chemo. So maybe you can more efficiently kill the cancer cell. And the idea would be to hope that you can spare healthy cells some of the side effects that we're causing. And so this is just a picture of the idea of an antibody-drug conjugate, where you develop an antibody that's targeting a receptor that's on the cancer cell surface. That antibody binds to that receptor on the cancer cell, but it's linked to chemo. And so if that antibody gets taken up into the cancer cell, it can release the chemo into the cancer cell and kill the cancer cell. But then there's one tricky thing that can happen, is that chemo can diffuse outside the cancer cell and get into the neighboring cancer cell and kill it. And that's what we call the bystander effect, where the chemo is not just killing the cell where the antibody bound, but it's also killing the neighboring cell. And this can be important because if the target where that antibody is binding is only on the cancer cell, then maybe the neighboring cancer cell is not going to get killed if it doesn't have that target right on it. But if you have this bystander effect, even if every single cancer cell doesn't have that target expressed on it, then you still could be very efficient at killing the cancer. And so these newer antibody-drug conjugates are able to do this very efficiently. And so you've already probably heard of this drug, sacituzumab govitecan, also known as Trodelvy. It's an antibody-drug conjugate that's targeting something called TROP2, which is pretty much uniformly expressed on really all breast cancers. And it's linked to chemo, where it links 8 different molecules of chemotherapy on just one antibody. So that antibody binds to the TROP2 receptor on the cancer cell, gets taken up into the cancer cell, then releases all its chemo in the cancer cell and kills that cancer cell. And then the chemo can diffuse out of it into the neighboring cell and kill it as well. And so here's just a picture where the schematic made the chemo be these little Trojans. And so you can see that the chemo's killing the cancer cell, but then getting into the neighboring cancer cell as well. And so when this drug, sacituzumab govitecan, was compared to standard chemo head-to-head, sacituzumab did do better than standard chemotherapy in metastatic hormone receptor positive breast cancer, where it kept the cancer controlled longer and allowed patients to live longer than standard chemotherapy. So we do utilize this in patients who have metastatic hormone receptor positive breast cancer. There's also another antibody-drug conjugate called TDXD, or trastuzumab deruxtecan. Some people call it Enhertu. I know it's hard when these drugs have like a million different names for the same thing. But the idea here is similar, that in this case, this is an antibody targeting HER2, and then gets taken into the cancer cell and releases its chemotherapy and kills it, and then also the chemo can go into the neighboring cell. One could think, well, maybe this drug would only work if you had a truly HER2 positive cancer, because then you have a lot of HER2 on your cancer cell surface, so that antibody can bind and the chemo can go kill it. And so initially this drug was developed in HER2 positive breast cancer for that very reason. But then they realized that the drug was also working even in patients whose cancer wasn't really HER2 positive, but it just had a little bit of that HER2 protein on the surface. It was enough protein there to allow the cancer, the antibody to bind and get taken up and kill the cancer cell. So you didn't really need to have a HER2 positive cancer for this drug to work. You just needed to have a tiny bit of HER2 there. And so it used to be, again, that we thought that cancers were either HER2 positive or HER2 negative, but we've now realized we can't really think of cancer cells this way. We need to understand if there's even just a teeny bit of HER2 on it. And the reason this is when they did a trial where they compared T-DXd, again, also known as Enhertu, to chemo in patients that just had a little bit of HER2 on their surface, so a cancer that we called HER2 low, that the T-DXd did much better than standard chemo. It kept cancer controlled twice as long and allowed patients to live longer. So it was dramatically better. And so this was in patients who had just a little bit of staining, we would call 1+ or 2+ staining of HER2 on their cancer cell and not being truly HER2 positive. But then we started thinking, well, what if we looked at patients who had even less in the way of HER2 on the cell? So maybe they didn't have a 1+ stain or a 2+ stain, but what if they had a 0 stain, but still had a little tiny bit of that protein on the cell surface? So something we would call HER2 ultra low. And here again, when they tested it in both HER2 low and ultra low patients, and this was in a trial where patients had never seen any chemotherapy before for their HER2 low or ultra low breast cancer, the T-DXd again did much better than standard chemotherapy. And so actually, just as of the 27th of January, we now have approval for T-DXd not just in HER2 positive, not just in HER2 low, but also in what we would call HER2 ultra low breast cancer. So it has really widened the number of patients that can be getting this type of treatment, but it does call into question, could this drug really work if someone has absolutely no HER2 expression, meaning what we would call HER2 null breast cancer? And there actually is a trial ongoing called Destiny Breast 15, where they're testing this question because the question is, can these drugs really work irrespective of having sufficient target expression? And that's something we just don't quite know yet. And then we also just got an approval over the last couple of weeks for this antibody-drug conjugate called datopotamab deruxtecan, or Dato-DXd. So this is an antibody-drug conjugate that's targeting TROP2, just like the sacituzumab drug we just talked about. But the chemo that it's delivering is deruxtecan. So it's the same chemo that Enhertu or T-DXd is delivering. It's just targeting a different protein than Enhertu is. And in hormone receptor positive metastatic breast cancer, when this drug was compared to chemo, it did keep disease controlled longer than standard chemotherapy. And so on January 17th, the FDA actually just approved this antibody drug conjugate. And so you can see there are a lot of antibody drug conjugates. There are 3 that are currently approved for metastatic hormone receptor positive breast cancer, and there are a lot more in the pipeline that are in development. The challenge that we have right now is all 3 antibody drug conjugates that are approved are delivering chemo that are a little bit related to each other. So they're kind of cousins of one another. And so we're not really sure how well these drugs work one after the other, because again, if one of them stops working, one could imagine maybe it stopped working because the cancer cell managed to develop resistance to that chemotherapy the ADC was delivering. So maybe the ADCs should have different chemo attached to them. And so that's what a lot of the newer antibody drug conjugates that are being studied in clinical trials are trying to do. And this is an example of one called disitamab vedotin. It is targeting HER2, just like Enhertu does, but instead of using the deruxtecan chemo that Enhertu utilizes, they've now used a totally different chemo unrelated to the deruxtecan called MMAE. And so one could imagine, even if your cancer is resistant to Enhertu, maybe this drug could work because it's using a totally different chemo that it's delivering. There are also many other antibody drug conjugates in development. This is called sacituzumab deruxtecan for short. Many of us are calling it SAC-TMT. This one is also targeting TROP2, and it uses a chemo that is a cousin to what both Dato-DXd and sacituzumab are delivering. So this is using a cousin chemotherapy that is what we call a topo-1 inhibitor. So the chemo is not totally different here. It's similar to the types of chemo that other ADCs are delivering, and again is being studied now in both hormone receptor positive and triple negative breast cancer. There's also this other antibody drug conjugate in clinical trials called patritumab deruxtecan, also known as HER3-DXd, because it's targeting a receptor called HER3, which is actually present on all subtypes of breast cancer, and then delivering the same chemo that Enhertu and Dato-DXd do. So again, a lot more to come. But I think the problem that we're running into now is, it's a good problem to have because there's so many drugs, is how do these drugs work one after the other, and how should we sequence them? Does it matter which antibody drug conjugate someone gets first versus second? How well do these work one after the other? And so I think this is a problem that we don't really know the answer to. And so there are clinical trials ongoing to answer this question. And this is an example of a trial that is currently ongoing where patients can get one of the antibody drug conjugates, and then if that drug stops working, then get switched to get a different antibody drug conjugate and try to understand how well these are working one after the other. In this case, it's using T-DXd followed by Dato-DXd, or Dato-DXd followed by T-DXd, and this is open both in metastatic hormone receptor positive as well as triple negative breast cancer. And hopefully studies like this will help us figure out if there is a right order and if there are ways we can help know in advance which patients are going to benefit from one drug being given right after the other, because at this point we don't really know. We're just sequencing them in patients and trying it and seeing how it works, but the truth is we don't have very robust data about that. So, I think the bottom line from all of this is that there are a lot of drugs that are really effective treatments for metastatic hormone receptor positive breast cancer. But as you can see, it does take getting a better understanding of the biology of someone's cancer to really know what the right drug is to give at a particular point in time. So I am often rechecking someone's cancer to know, oh, does the cancer now have an ESR1 mutation? Does it have a PI3 kinase P10 or AKT alteration? How much HER2 is on the surface? Does that patient have a germline BRCA mutation or PALB2 mutation? Has the tumor acquired a HER2 mutation? Does the tumor have a high tumor mutation burden? All of these things are things that an oncologist wants to know to figure out what the right drug is to give. And so it is really important to get genomic testing in the setting of having hormone receptor positive breast cancer so that we can help figure out the right treatment options. And so this is, I think, maybe a little bit overwhelming, but I think it goes to show the complexity of making decisions because, again, in a good way, we have so many choices. We need to be very thoughtful in how we're making those decisions. And so this schema is trying to say, well, generally speaking, we're often giving an endocrine treatment and CDK4/6 inhibitor, but when it stops working, we need to check to see what mutations there are, and then based on the mutation, figure out which drug to give. And I would argue now we need to be testing even upfront to know if someone has a mutation so that we can add in a PI3 kinase inhibitor in the first treatment versus saving it for later. And so I think it just shows you there's so many different treatment options and we're still trying to figure out optimal sequences, but nice to have so many choices. And as you can see, there keep getting to be new approvals all the time. And so this space is really changing very fast. And so, on the horizon, I think there are many new hormone type therapies. We didn't get into the details of all the different types of oral SERDs, Protac, Serans, SERMs. There are lots of different hormone type medicines. We touched a little bit about drugs that are just targeting CDK4 and sparing CDK6. So drugs like atirmociclib. There are better and better ways being developed to turn off the PI3 kinase pathway with those new mutant selective inhibitors. There are other drugs that can target hormone resistance that are in development, things like KAT6, CDK2, lots of novel drugs in that space. And then as you could see, there are lots of antibody drug conjugates that keep coming where the idea was trying to change something about the drug, maybe change out the chemo, change out the target that's going to allow us to get one of these drugs to work one after the other. So in my mind, I think we're seeing so much progress day after day come in this space, which is tremendous. Again, you can see all these new drug approvals really, impressively coming at a fast pace. And so I will say I just continue to be very hopeful that we're going to continue to do better and better for patients with hormone receptor positive breast cancer. So thank you so much for your time today. And I'd be very happy to take any questions that people have.
Great. So just as a reminder, it's immediately to the right-hand side of the green share arrow at the bottom of your screen. That's the Q&A. If you guys could post your questions there, I know a few have been posted in the chat. If you'll just move them over there, we can make sure we can answer as many as possible. But Dr. Tolaney, we do have someone who's asked, are there cases or have there been cases where metastatic breast cancer patients can take a pause in their treatment plan in order to start a family?
Yeah, that's a really complicated question, I'll say. I think the challenge that we have is when someone has metastatic breast cancer, it means that there are cancer cells that are present, usually in the bloodstream, that have landed somewhere else in the body. And so in essence, we're usually keeping people on some type of medicine at all times, really to keep those cancer cells controlled. And so if someone stops those drugs, the worry could be that cancer cells would start to grow and divide again and could cause problems. And so I think it's a question that's an excellent question that I don't have a great answer to, excepting it's something that I think would need a significant discussion with your oncologist, because there is risk in that situation, and we would need to understand a bit more about the situation with the cancer at that time.
Thank you. And what are your thoughts on re-challenge with estrogen therapy after Enhertu has been used?
So that's a good question. And so the question is, if someone's had Enhertu or T-DXd, do we ever go back to giving hormone-based medications? Because often the paradigm, as you could see, was we were usually starting off with hormone-based therapy. Once they stopped working, we sort of moved on to giving either T-DXd or chemotherapy at that time. And so do we ever then go back and give a hormone medicine? And sometimes we do. It depends on the situation. I've had patients where maybe I got a little bit nervous about the pace of the cancer, and I switched quickly to giving maybe chemotherapy type treatments like an antibody-drug conjugate. But then the cancer got amazingly controlled and wasn't growing at that fast pace anymore. And so maybe that's a time when one would switch back to using an endocrine-based treatment. And so I think it's a complicated question. It would depend on the scenario, but certainly that could be an option for some patients.
All right. And we have had a lot of questions about getting a recording of this, and one will be delivered to the email you used to register for this event. So no worries on that. You're going to be able to rewatch and, kind of study this information. Dr. Tolaney, what test is better? And I'm assuming this is for screening. What test do you recommend? Is it a 3D mammogram, or are there other 3D tests? And maybe I've misunderstood the question.
So it sounds like maybe the question is about if someone's looking to see if they could have a breast cancer, what's the best screening test to do? And certainly a good question, and maybe a little bit of a controversial question, but generally speaking, we do mammography. Even that's a little controversial, but most of us tend to recommend an annual mammogram starting at the age of 40. If someone has a strong family history or has genetic predisposition, those recommendations can be different. So for example, if someone had a BRCA mutation, we will sometimes start screening even as early as the age of 25, using MRI alternating with mammography every 6 months. In terms of the type of mammogram that's used, most centers have switched over to doing 3D mammography. It's become pretty standard at most centers. There are other techniques that are sometimes offered. There's now a new type of mammography called contrast enhanced mammography that looks to be really on par with MRIs, but not really routinely being done yet at most centers. And so, I'd say for now, most patients should be getting annual mammograms for screening starting at the age of 40 if you're at average risk, but certainly if at higher risk, a discussion needs to be had about the optimal screening tools and timing.
Thank you very much. We've been asked, or questions come in, why can hormone positive breast cancer be hormone resistant from the onset?
Yeah, it's a good question because, I tried to show this picture, right, that made it all seem so simple that there's an estrogen receptor, there's estrogen, it's feeding the cancer. And so you would think you just get rid of that estrogen. Well, then that cancer cell can't grow, it should just die. So why would it ever be that a cancer from the get-go wouldn't respond to getting rid of the food supply? And it's a rare situation where someone has what we call primary endocrine resistance, meaning that cancer's never been sensitive to any type of hormone-driven treatment. And we think that can happen for a number of reasons. And so if you remember some of the pictures I showed where downstream from the estrogen receptor, there are a lot of other pathways that get activated. And so if you develop other activation of other pathways that are driving your cancer to grow, then your cancer stops ignoring what we're doing to the estrogen receptor because it's already growing because it has other pathways activated. And so again, that's an unusual situation. Usually those kinds of resistance mechanisms arise because we've exposed a cancer to estrogen therapy. But in 5 to 10% of cases, we sometimes do see primary endocrine resistance.
We have a question about, especially with some of these new drugs, either coming to market or in trial, that, the encouragement would be to have the liquid biopsy and, do the gene sequencing. How often should that be done? Should that only be done when you're starting to see progression or maybe another symptom in a metastatic breast cancer patient? Or is it something that should just be done routinely, like X number of months, like we do PET scans or other scans?
Yeah, also excellent question, and one I don't have a perfect answer to. So generally speaking, I like to get the sequencing when someone's newly found to have metastatic breast cancer. So that would be one time point where I think it should be done. Then after someone's had their very first treatment, usually that's endocrine-based therapy, if the cancer grows at some point on that treatment, I want to understand why did that cancer grow and what's driving the resistance. So then I check again. That could either be that you get a biopsy of the tumor or you get a liquid biopsy, so a blood assay to help understand what those mutations are. And then let's say someone gets another treatment and that cancer grows after that second treatment. I sometimes will recheck. It will depend on what I found on the previous blood draw or biopsy, because if that patient didn't have an ESR1 mutation before, then I'm trying to look again, well, maybe they've acquired one now. So I'm going to check. But if they already had those mutations, they had PI3 kinase and ESR1, then I'm not likely to find another mutation that's really going to change treatment, with the exception of use of drugs on clinical trials. And so it depends kind of what there was and what I'm looking for to help me figure out if I need to keep rechecking over time.
Okay, great. Thank you. Sounds like that is kind of a to be determined.
Yes.
We have progression and maybe on some type of schedule as we learn more. So this is near and dear to me. I have a very widespread, I have widespread metastatic disease in my bones. I know a lot of other metastatic patients who are the same. It's painful. It's just something that we're always thinking about. And so these drugs, do any of them actually get into, that where that metastatic disease is in the bone itself? I mean, are they treating the metastatic disease, or they're really just holding the cancer at bay so it's not growing any further?
So all these drugs that we're talking about are systemic drugs, meaning that they should get in no matter where the cancer is, if it's in the bone, if it's in the liver, if it's, somewhere else, the drug should be penetrating and killing cancer cells irrespective of location. So, they should be doing that job. Whether or not, to your question, is a good one. Is it really shrinking the cancer, or is it maybe just keeping it stable? That is also dependent on how sensitive the cancer cells are to that drug. Sometimes they shrink beautifully, and other times, they keep the cancer stable and don't allow new spots to develop, but maybe haven't shrunk it a lot. I think one of the challenges we find is it's a little hard to always know in the bone, because it's not like, if someone has a mass that you can see on a CT scan, you can say, hey, one day it was 3 centimeters. The next time I measured, it's 1 centimeter. Oh, it shrunk, right? That was clear. But in the bone, it's not so, like, I can't tell a patient, oh, you had a 2 centimeter bone metastasis that's now 1 centimeter. It's usually that you're seeing changes in the bone, that then you're kind of seeing what happened to those changes. Did they look like the bone's healing now? Does it look like those areas are extending more? And so sometimes it's a little harder to quantitate in the bone, which makes it a little bit tricky.
Okay, thank you. Can you share some information about the Canberra-2 clinical trial?
Sure. So the Cambria-2 study, it's actually a trial that's for patients with early stage breast cancer. So if someone was newly diagnosed with a hormone receptor positive breast cancer and had finished their surgery, and let's say they needed chemo or they didn't need chemo, whenever that part was done, and they were going on to start hormone therapy, the Cambria-2 trial is trying to understand if you give oral SERD, so a medicine that's chewing up the estrogen receptor. In this case, it's camizestrant, a drug made by AstraZeneca. It's comparing it to giving standard endocrine medicines such as tamoxifen or an aromatase inhibitor. And so it's comparing camizestrant head to head against what we would normally give in this setting in a newly diagnosed hormone receptor positive breast cancer patient. So I think it's an interesting trial, because we do think these new oral anti-estrogen medicines seem to be very effective for metastatic disease. So now we're trying to say, will they also do better for early stage breast cancers?
Okay. We always, when you're the patient, you're always worried about when the treatment will stop working and how many options you have when you have to move. So we have a question. If you've had Faslodex and the CDK 4/6 as your first line, can you maybe use another CDK 4/6 with the Faslodex for effective control of the cancer? So, for example, if I'm on Ibrance, would you change me maybe to Verzenio and see if that worked, or these new drugs that are more specific to any mutations where how the cancer is sort of reacting? Is that a better kind of next step?
So sometimes we will change someone from one CDK4/6 inhibitor to another. There is some data to suggest that this could be effective. There are trials that have looked at using ribociclib, for example, or abemaciclib in patients that have seen a prior CDK4/6 inhibitor. But these trials also changed the hormone medicine that patients were getting. So, for example, if you were getting an aromatase inhibitor and, let's say, palbociclib as your first treatment, and then your cancer grew, the trials were saying, well, could we give you Faslodex with a different CDK4/6 inhibitor, either, let's say, ribociclib or abemaciclib? And it did seem like that strategy did better than just continuing a hormone by itself. So sometimes we do this. I think this space is a little complicated because there's so many choices for what to do in this scenario after someone's cancer has grown on a CDK4/6 inhibitor, that I do like to get the genomic testing done to really help me figure out what the best strategy is, because there are so many choices. And if someone has an ESR1 mutation, or if they have a PI3 kinase pathway mutation, I may decide to do something different. And so I would want to know all the information in that time to know what makes the most sense.
Well, thank you, Dr. Tolaney. This has been amazing. so much to learn, and we are also hopeful that there's even more coming after this. So I appreciate that. And Casey, I'll pass it back to you.
Thank you so much, Carly. I was just trying to reorganize after initially getting through as many questions as possible. Thank you, Dr. Tolaney and Carly, for trucking away and trying to hit as many as possible before we ran out of time. I truly appreciate it. Dr. Tolaney, there have been several thank you comments in the chat as well as the Q&A. They're grateful for the information and to get the recording. They also, there's a lot of chatter and questions regarding sending out the slides. So would you be all right if I shared those with the attendant? Perfect. So team, you heard it straight here. I'll be making sure I send those out with the recording after the event. So again, thank you to both of you for your time and your consideration on all these questions. You guys went fast and furious in the Q&A. I'm so grateful. And I so am truly, truly sorry that we didn't get to more or all of them. But it was a recorded session. Like I said, we're going to send out the slides. So you can rewatch, you could share, you can study the slides that we had to zip through. And you can always visit our landing page to learn more about future events and sign up for our newsletter to stay informed. So komen.org/MBC series is how you're going to stay connected. And once again, I just have to thank our sponsors, because without them, we wouldn't be able to bring this information to you. So thank you to our premier sponsors, AstraZeneca, Merck, and Gilead, and to our signature sponsors, Daiichi Sankyo. Last but certainly not least all, I'm going to beg you a little bit here to help fill out the survey, which I'm dropping in the chat feature now. It's very quick and it's very, very helpful for me when I'm designing these topics and seeking out speakers. So what do you want to learn about? Who do you want to hear from? What did you enjoy? What could we do better? Please put it all there for me, and so we can address all of that in future sessions and future program planning. Finally, the next MBC Impact Series will be February 26th, and it is going to focus on metastatic triple negative MBC. Like I said, every month's a new topic. So if interested, or if you know anyone who would be interested, you can sign up now on our landing page or share that link. So thank you again to everyone for joining today. Again, sorry for not getting through all the questions. If they're in the Q&A, I'll tease through them after and see if we can't send out some additional answers after the fact. I'll do my best, guys. Enjoy the end of January and happy February. Thanks all.
Thank you, everyone.
Thank you, Casey. Thank you, Dr. Tolaney.
Thank you guys so much.